afternoon. It's Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have the pleasure of hosting Oscar Alves, heading the Cervical Spine Research Society. This is our third webcast. So I'll turn it right over to Oscar. Welcome, Oscar. It's all yours.
Thank you, John. So I appreciate for being here. This is our third CSRS Europe webinar. We have very distinguished faculty from all around the world. My co-host is my colleague from the board, Dr. Jesus Lafuente from Spain. We try to organize very sharp questions that can solve some of the clinical dilemmas we have in our practice. So the topic today is when to extend a cervical construct to the occiput or the thoracic spine. So without any further delay, I'm calling Mehmet Zileli from Turkey, professor of neurosurgery in the Egg University in Izmir. He's chairman of the World Federation of Neurosurgical Societies of the Spine Committee, and president of the Turkish Neurosurgical Society, former president of the World Spine Society. He's a well-known educator and a very, very distinguished surgeon. So Mehmet, to you.
Thank you, Oscar. It's a great pleasure for me to be with you. I know most of the friends that are connected already. And my task is to explain something about how to extend the fixation to occiput, when to extend it to occiput. I believe first there is a problem about occipitocervical fixation because there are many unnecessary occipitocervical fixations. Many cases with C1, C2 instability only have traditionally gone occiput C1, C2, even lower cervical spine fixations. However, occipitocervical fixation significantly restrict head movements, and it has a quite well-known complications. One of them is the high non-union rate. If you look at the anatomy of the region, occipitoaxial joint is a very strong joint, and the strength of the ligaments and the orientation of the joint surface provide remarkable stability. So the disturbance of the occipitoaxial joint is quite uncommon. However, atlantoaxial joint disturbance or instability at this joint is quite common, and many instabilities at the region is really just an atlantoaxial joint instability. If we look at the complications of occipitocervical fixation, CSF fistula is one of them. Cerebellar hematoma because of the penetration of the dura and the cerebellum with the screws. And there are hardware-related complications which are more common. Screw loosening, pseudoarthrosis, and even instrument breakage may happen. This is one of my cases which had a rod breakage after a occipitocervical fixation. Both rods were broken. The complication rate has been mentioned in the literature by many authors. But the most common one is the pseudoarthrosis and non-union at the region. If you use allografts, if the bone quality is low, like diabetes, rheumatoid arthritis, smoking, if there is a significant deformity at the region, and if there is a hyperlordosis, non-union rate will for sure will increase. And in the past, we were doing many long fixations with applications to all cranioscervical pathologies without reduction. But currently, we have good knowledge about the instability of the region. And we are doing shorter fixations, separate indications. We make most of our fixations after reductions. And these are the absolute indications. If there is a traumatic occipito-atlantal instability, it is quite rare, very uncommon, and most of the cases are fatal cases. They die after a while. Occipito-atlantal instability due to basal invagination, if it is irreducible, which is not very common actually. Most of the cases you can reduce by application of good reduction techniques. If there is atlas assimilation or dyskinesis of C1 lateral mass or occipital condyles, you can also, because you cannot place a good screw purchase on the C1, and those cases may go to occipito-atlantal fixation. Tumors and infections and tuberculosis invading that joint, occipito-atlantal joint, and rheumatoid basal invagination. Why I mention this? Because those cases do have mostly bad bone quality. Relative indications are odontoid resection, Down syndrome, cases with osteoporosis, irreducible rheumatoid atlantoaxial dislocations, complex C1, C2 fracture dislocations, and revision cases. If we try to obtain an algorithm for making an occipitocervical or atlantoaxial fixations, if it's trauma, the question must be whether one of these if it is reducible or irreducible, then your choices will change accordingly. However, if it is a non-trauma case in the upper cervical instability, then again we ask occipitocervical or atlantoaxial instability, presence of such instability, and if it is reducible or irreducible. Whether we have to apply a traction is still in discussion. We don't have good recommendations for that. But occipitocervical instability and fixation, necessity of fixation is not very common in non-traumatic upper cervical instability cases. Should we, how long shall we lengthen our fixation? Shall we stay only C1, C2, or just occiput C1, C2? Case-based evaluation is necessary. Ideal is, like you see on the left, C0, C2, or C3. Cases with basal invagination when to add occiput to fixation, if not reduced and need odontoid resection, and if C1 assimilated, we need to make such fixations. Shall we go lower levels in tumor cases, in hyperlordotic cases, in some rheumatoid arthritis cases? Yes, we shall go. In conclusion, occipitocervical fixation restricts head movements and has a very high non-union rate. Unnecessary occipitocervical fixation must be avoided. The main problem is the decision for whether an occiput C1 or C1, C2 instability present. And most cases have only C1, C2 instability, and occipitocervical fixation is not necessary. Thank you. Thank you for listening to me.
Thank you very much. Mehmet, great talk. Can you hear me?
Yes.
I think you raised a couple of very, very good points, and I think this resumes very much your talk. There are more non-union, and I've seen, and I have to congratulate you because you've been extremely honest. You show pictures of your cases with fracture rods and so on. And that
Sorry,
means
Jesus?
that, yes?
I just launched a question here, so people
Oh, sorry.
can vote. Mehmet gave us some questions. So choose one of the conditions where the occiput must not be included in the fixation. There are here several options. And the second question you see in your screen, what is the most common complication of occipital-cervical fixation?
I can't see anything.
Okay, so gonna stop the inquire. I'm gonna share the results. Okay, so everybody see the results here?
Yes.
So choose one condition where the occiput must not be included in the fixation. And most of the people believe it's basilar invagination and then plateaux-axial subluxation. But still other people said that other conditions should not be included. And regarding the most common complication, pretty much everybody understood the Mehmet message, and really non-union is the most frequent complication. Mehmet, any comment on the polling?
Yes, this is good to see that most of the response are the one that I wanted to choose. Yes, C. In the first question, the right answer is C, basilar invagination and atlantoaxial subluxation. In those cases, we must not include occiput. This is the main message.
Exactly.
The second question is non-union is the most common complication of the region. This is true. But since some friends have chosen the other A, B, or D, or E in the first question especially, so there is still a confusion in the heads of some participants. We must discuss those issues later on.
Excellent.
Yeah.
Okay, so does anybody want to make a question to Dr. Zileli?
I just wanted to ask him can I ask a question?
Yes, please.
Yeah.
Sure, please.
Mehmet, when you talk about non-union, I think this is a very important aspect. I work with Crockett, and Crockett had also non-union. I had to look after the patients when we operated on those. One of the things that I found important and interesting is by putting C0 screw to the lateral mass or to the occipital condyle. This is less often because I think there's a less torque force. You reduce the dural and the hematoma in the cerebellum, and also you can monitor the 12th cranial nerve before leaving the screw definitely. Did you have any experience with C0 or condyle screw? And if so, what is your impression?
I didn't use condyle screw anytime. It may be, I'm not sure for that. But as I know, the biomechanical studies do not support that too much, as I know from the biomechanical studies. However, it may be. I don't have the experience with that.
I mean, the theoretical
sometimes
that you could reduce the lever arm.
Yes.
And less.
You reduce the lever arm, and sometimes when you have craniocervical malformations where you need to remove some part of the bone, of the occipital bone, then you have very little space to put a plate in a soft or the thinner part of the bone, and the best option there, I believe, is the condyle screw for that particular cases.
So there is a question here, Mehmet, from Dr. Shifa, asking what you do to improve the union rate in C0, C1, C2 fixation. Yeah. What's your special tricks?
Yeah, we must almost always use the autografts instead of allograft. Second, we must not be very fast at the end of the surgery during preparation of the fusion bed. Actually, especially the neurosurgeons do not take care of the preparation of the fusion bed. We must decorticate the occipital bone and decorticate the C2 lamina and spinous process and place autografts in between. We must be very careful about this. In fact, we were having more non-unions in the past because we had less rigid fixations. But by increasing the rigidity, we now have less non-unions than before.
Exactly. Mehmet, a very quick question before we go for the next presentation from Jerônimo Milano from Brazil. Is asking if in rheumatoid arthritis, do you always include C0 or only if you have concomitant osteoporosis?
Yes, if there is concomitant osteoporosis. If
not always, not always.
Not always,
yeah.
Not always. But if there is rheumatoid basal invagination, actually, maybe we must divide it in two phases. Actually, in the beginning of rheumatoid instability, it is just C1, C2 instability. But after a while, if it is neglected, a rheumatoid basilar invagination adds to that instability. In that phase, we must do an occipital fixation.
Very good. Thank you, Mehmet. So without further delay, and some of the questions will come later on the occiput extension, I call Dr. Jamel Kitumba. Dr. Kitumba is from Angola. He's a neurosurgical fellow at my department in Portugal. He's a very young man and very interested, very knowledgeable. And I invite him to show here a very simple case, but nice for discussion. Go ahead.
Is it okay? It's showing well?
Yes, Jamel, go ahead.
Okay, good afternoon, Thoracic. Good afternoon, Dr. Lafuente, and everybody watching us. It is a great honor for me to participate in this webinar with such distinguished panelists. And I'm immensely grateful for this opportunity to learn from you guys. So I'm going to start just here. This is our case. Beautiful case that I found in Dr. Oscar's archive. It's a 54 years old female with a long history of
sorry, hold on, Jamel.
Yes. Should I start again?
Yes, we should mute all because we have some interferences. Jamel, please start again. Thank you.
Okay, as I was saying, first of all, thank you for this opportunity, and I'm immensely grateful to learn, to take this opportunity to learn from you. This is a beautiful case from Dr. Oscar's archive, and a 54 years old female with a long history of posterior neck pain that irradiated to the occiput and the progressive history of hoarseness. She had no swallowing complaints or other neurological deficits. She came up to our department with this cervical x-ray where we could see the fusion of C2, C3. We couldn't see the posterior arch of C1. And we see here a posterior translation of C2 away from C1 in the flexion position. So we asked for this CT scan and we confirmed that there was a simulation of posterior arch of C1, as you can see here. Yes, there was a fusion of C2, C3. There was an increased distance of the odontoid away from the anterior tubercle of C1, and there was a superior or cranial position of the odontoid tip. Yes, we can confirm here there was anomalous position of the odontoid tip. It was 8.8 millimeters above the chamberlain line. There was an increased AADI of 7.6 millimeters, and there was a decreased cleval canal angle of 145 degrees. as we would suspect from that CT scan, there was a significant compression of the bulbomedullary transition caused by this retroflexed odontoid tip, and even in neutral position, as we do as we can see in this MRI. So based on that, on those radiological findings, the following features all were present except for one. Which do you think it is, Dr. Oscar?
Yes, please go. People can vote now. So the following features are present except a similar simulation of C1, dystopic orthodontidium, basilar invagination, clipal file. Okay. Not many people voted, but also the Tondio. Actually, there is no criteria of okay.
Yes, I think there's no much of a doubt here.
Okay, just go ahead.
Can I move forward? Okay, just to remind, this is a 54-year-old female with atlas assimilation, a C1, C2 instability, plus neural compression by reducible basilar invagination, and an anomalous C2, C3 vertebra. What would you propose to this patient as a treatment? Dr. Oscar, can you?
Yes. People can vote now. Posterior decompression only, Occiput C2 pedicle screws, Occiput C2 laminar and go down to C3, or only a C1, C2 fixation. Okay. So people can vote. Actually, this is not working nice. Okay,
Yes.
so go ahead, please.
It's not working. Yeah?
No, just go ahead, please.
Okay, I will show now what we've done. So,
but yeah.
Sorry.
Yeah, let's go ahead. Go ahead.
So we've performed here a small suboccipital craniectomy and did a posterior internal fixation, the occipital cervical fusion. We put here an occipital plate and extended our fusion to C4 pars. Because C2 and C3 were fused, they shared their lamina, so it was a big lamina, and we put screws there. As we can see in this 3D reconstruction, we were happy with the upper cervical and overall cervical alignment. And the translaminar screws had a very good purchase, and the thickness of the occipital bone was great too. So we felt that the construct were very rigid. We achieved here also a good correction of the atlantodental interval, and a good reduction of the basilar invagination, as we can see here, with a good decompression of foramen magnum and restoration of CSF flow. Now appeared here these lines, these yellow lines. I don't know. It was not me. Sorry. Okay, the surgery was uneventful. The patient was discharged on the third postoperative day. She was symptom-free at the discharge, and after 7 years of follow-up, she's very satisfied with the results, and we also. Atlas assimilation is one of the most frequent craniovertebral joint anomaly. It results from a segmentation failure of the fourth and first occipital and first cervical sclerotum. There is questioning about the genetic role of these genes, the OXA3 and OXD3, and it's not uncommon to appear associated with other bony anomalies that we've seen in this present case, and it is often associated with atlantoaxial dislocation. This is a biomechanical study based on a finite element analysis in which the authors confirmed that the atlas assimilation is linked with the hypermobility of the atlantoaxial segment, Because in this condition cause an overstress of the transverse ligament and lateral atlantoaxial joints that linked with another bony anomalies leads to instability and basilar invagination as a consequence. And because it is a dynamic process, it is a dynamic pathology, some patients start even not without a compression, without neural compression, and with a reducible pathology, just to evolve to a more severe state. So these patients must be followed closely. So we think that patients with intractable pain or with clinical or radiological confirmation of neural compression should be recommended for surgery. The compression alone is not advised. We've seen that the onus or the onus of the pathology depends on the instability, on the presence of instability. So it is a good indication to do a posterior internal fixation. The presence of atlas assimilation is a good indication to include the occiput, as we've seen also in the previous lecture. To do a C1, C2 fusion is biomechanically now being studied and proven by some authors, but we think it could be hindered by the patient anatomy. Sorry, it should be done if the occiput is hindered by the patient anatomy, or if extensive previous bony decompression was already done. And to do an OCF, it comes the question where to end the instrumentation. It is on C2 or one or more levels below. In our case, we chose to go another level below just to reduce the lever arm and reduce the instrumentation failure risk in this case. And we were satisfied. That's all I had to say. Feel free to comment, Dr. Ashkar. I think I'm done here.
Thank you, Jamel. Very nice presentation. It's a really simple case.
Oscar, you listed yourself.
Yeah, thank you, Jamel. Very nice presentation. It's rather simple case, but you didn't show, but the isthmus of C2 was quite difficult to pass a screw. So we decided to do a translaminar screw in C2 and felt that could be some pressure, some pull-out chance on the C2 anchoring. So we decided to go down to C3. So Mehmet, what do you think about
I have one small question.
Yeah, please go ahead.
Oscar.
Yes, please.
Do you know, is there a literature information about the rate of atlas assimilation in basilar invagination cases? What is the rate? What is the percentage of atlas assimilation in basilar invaginations?
Jamel?
Actually, it's very common to come for them to come associated. There are some literature that says about 35% or even more, because the clinic, these patients often are presents with the because of the neural compression, and there is no neural compression cause. I'm sorry to say this is more for the other guys. It's caused by basilar invagination, and most of the time patients are seen because of basilar invagination, and
35%, you say?
Yes, yes.
Thank you.
So Mehmet, we had previously here in the first webinar, Atul Goel was giving a lecture on the cervical junction surgery, and he was claiming that assimilation of C1, it's not a formal indication for occiput fixation. It can solve only with C1, C2.
He says even in those cases, assimilated C1 may be the fixation point.
Yes.
But I doubt if there is any difference between assimilated C1 fixation or midline occiput fixation. There is no biomechanical studies on that.
And not to talk about the increased risk, because you don't see the landmarks quite nicely.
Exactly.
as in a normal case.
Oscar,
Yes.
can I have a question?
Sure, please.
There is one important complication which hasn't been mentioned so far. This is loss of forward or horizontal gaze during occipital cervical spine surgery. We know that craniocervical junction is responsible for horizontal gaze, while the subaxial cervical spine is responsible for that game of sagittal balance together with thoracic and thoracolumbar spine. So, have you any clue how to avoid loss of horizontal gaze when stabilizing spine from occiput down the cervical spine?
Yeah, I mean, this is really a very nice question, Andre. What we do is intraoperative. Before we start to do anything, you position the patient on prone and you do an X-ray, okay? And taking from that, that's the final position of fixation. And I fully agree with you. I've seen terrible problems of fixation of the head in protrusion, and the patient just really can't breathe, can't eat. And the other thing is when the other thing is whenever you position the patient on prone and you see the trapezius muscle is contracted, it's probably not a good positioning. So it's a combination of X-ray, intraoperative X-ray that you assess.
Oscar?
Yes.
Yeah. I use usually all the information that you presented, and I add for surgical planning the angiography, the vertebral angiography. Have you done in this case? And I would like to know which of you have neuronavigation ready to use in those cases.
We have not done angiography. We don't do it regularly, except for very complex cases involving tumor cases, for example. I think on this kind of cases, the surgical anatomy, the bone anatomy that you can get from well-performed CT scans are quite confident to do the procedure. And we don't have navigation as well. So we rely on lateral X-ray and intraoperative viewing of the middle wall of the pedicles of C2 or the lateral mass of C1.
Oscar, Atul is with us in the meeting, and we can probably ask him about the horizontal gait, lack of horizontal gaze. It is a really very interesting question.
Yes. Atul?
Can I answer that?
Please, Atul. Thank you.
See, first, number one is this, thank you for inviting me to this wonderful show. As you know, basilar invagination is a very, very important subject. And if you treat it properly, you give absolutely new life to the person. And on the other hand, you do not treat properly, you create a lot of complications. And you can have a very miserable death. That death following complication can be absolutely devastating to the patient. So my experience with basilar invagination has been for a very long time. And I used to do occipital fixation. Now I have completely abandoned inclusion of occipital bone in the fixation construct. My feeling is inclusion of occipital bone and including of long implants, like from occipital bone to C2 or C3, these long implants are very, very biomechanically flimsy. You move your head and you can dislodge your implant. My feeling is it is difficult to expose C1, there is no question, but C1 plus occipital condyle, they both in assimilated atlas, it makes a very solid, huge rock of bone. And you can introduce a big screw, 26, 28, 20, 30 millimeter, absolutely long screw you can introduce into that. You can open the joint and you can introduce bone graft. So in short, my answer to basilar invagination is only C1, C2, no matter what is the other situation, no matter whether there is assimilation or not. The other question that was asked about gaze issues. gaze issues, dysphagia, and a host. See, dysphagia is a very important complication of inclusion of occipital bone. Your whole neck can become in a very abnormal kind of position. So focal segmental fixation at C1, C2, difficult operation, particularly when assimilation of atlas is there, is quite difficult. But difficult does not mean that it is not the best. The best is open the joint, introduce bone graft, introduce C1 screw, introduce C2 screw. That is the best.
Cool. Thank you so much for this insightful opinion. I have to tell you, this is a very old case of mine from 2011. So now I'm sure I will do it differently.
Yeah, the other thing I was going to ask you, Oscar, in this particular case, although I know it's old, hello Atul, hello everyone, again,
Jesus.
the fact, do you have flexion extension views? Because if you have flexion extension views and this is mobile or reducible, then a posterior approach seems to be the reasonable approach. If, in the other hand, this is not approachable, in the MRI you can see a big kink on the spinal cord and the brain stem, and maybe now with the endonasal techniques you can remove part of the lower part of the clivus and the odontoid peg if you want to do, and you are committed to do, C0, C2, and then decompress from the front and go from the back. Because I was surprised that it was reduced, and if it was reduced, then it's great because you don't have to do anything from the front, which is always a big complex or potentially complication. But if you don't reduce, then you are pushed towards the compression from the front.
Okay, Jesus, it's a good point, but I'm with Atul on this topic now. I think most, if not all, of the basilar invaginations are reducible. We need to move forward, and I call now for a second case on this topic. Jyoti Parthiban is an eminent surgeon from the Department of Neurosurgery in Coimbatore, course director of the National Board Diploma in India, very experienced surgeon. Jyoti, thank you so much for being here with us.
Thank you. Are you able to see my slide?
Just put it on full screen mode, please.
Is that okay?
Yes, perfect.
Yeah. I'm audible also. I'm audible?
Yes.
Yeah.
Okay, thank you. Tuberculosis is very common in our part of the country. You know, this world on the Asian side, tuberculosis is very common. And we come across tuberculosis in mostly in the complete spine. The whole spine we get tuberculosis. But very specific and more exciting one is something happened at C1. Tuberculosis is something we see quite often, and our management protocols changes very widely. This one particular subject is treated in all ways, in all aspects, either medically or surgically. I give you only two small cases with very minimal presentation with minimal slides. Now, here is a professor who is of middle age, he's a male, and he has no comorbidity, he had no previous history of any treatment, and there's no family history of any infectious disorders. He came with the torticollis, and this is the position, the way you can see him holding his hand and over the head and positioning the head. He had a very severe neck pain for nearly a month, and he was seen by a physician, and he was put on a collar. He had no fever and no injury. The neck was tilted towards the left side, and the face rested on the left hand always. The moment you take it out, he gets severe pain and he cannot tolerate. Being a professor, and he was not able to go for his job, and he was not able to give the lectures. So he said he wanted to consult, and then he has taken an X-ray, which showed a very classical Cock-Robin torticollis. So he had no neurological deficit, that's all. So this is the clinical presentation with this middle-aged man who came with this. And he underwent a very strategic radiological pictures, both CT scan and also an MRI. Here you can see the CT scan, which shows C1, left lateral mass, is completely eroded. And the superior facet is also eroded. The inferior facet end plate was pretty thinned out. So you finally see that the complete lateral mass is eroded with some kind of a disorder. We do not know. But when you see an MRI, in T2 weighted image, you can see a signal changing, showing a classical tuberculosis, which is very correlating with the tuberculosis. It's not only in the left lateral mass region, but it is extended slightly anterior and posterior. So these are the very salient pictures I have shown. Now, we have taken the other cuts. You can see in the lateral X-ray, there is no dislocation. And quite fine. The C1, C2 looks good. But when you see the cut sections of these pedicles, you can see on the C2 pedicles, on the right side, it's very small, 2.6 millimeter. On the left side, the pedicle is very good. It's quite 5 millimeter thick. Now, how will you manage this case? This patient has only one indication. That's a pain. That's all. Nothing else. Restricted neck movement and pain. Patient was given with a collar, and patient had only medication. So how will you manage this? Whether we can do a conservative with some kind of a biopsy or a bit of hard collar and antituberculous treatment, or an anterior approach or posterior approach.
So GT, I
Okay.
open to voting.
Yeah.
People are already voting. Allow some more time. A lot of people voting, enjoying your case.
Yeah, I understand. I can see that.
Okay. So I'm gonna close it and share the results. So most of the people, Jyoti, would go for a posterior approach. Nevertheless, 1/3 conservative approach with a biopsy, hard collar, and TB.
I agree with that.
And concerning the posterior instrumentation, people split in three. I mean, C1, C2 fixation, Occiput, C1, C2, or Occiput extended to C3, C4.
Yeah.
Okay.
Yeah. I can see that. Now, taking the first one, how will you manage? Yes, you can manage with a conservative, totally conservative. You can do a percutaneous biopsy of the lesion, and you find it. And if it is tuberculosis, put the collar, give the antituberculous treatment, that's fine. Now, the only problem in the conservative treatment is that the pain reduction is not going to be quick. It's going to be problematic. So the only way you can reduce the pain is by doing some kind of a fixation technique. And I agree with the posting that the posterior approach is more comfortable in this situation. So on the second aspect, what kind of posterior instrumentation can be used? It's a very, very widely distributed voting here. C1, C2 fixation is agreed. That is from the posterior aspect. But when you carefully look C1, C2 fixation, it should be on unilateral aspect. We have to think about unilateral, because on one side, the C1 lateral mass is gone. So we cannot put a screw on one side. So only on the other side we can put, that is on C1, C2. Now, if you carefully look on the right side, this is the left side lesion. On the right side, the pedicle is very small. At the maximum, you can catch up a pass. So whether unilateral fixation is okay, I'm not very sure, but it is possible. The second thing is Occiput and C1, C2. Again, it should be more of unilateral on Occiput, C1, C2 on the right side, maybe on the left side. You cannot put anything on C1, you can put from Occiput to C2. The other thing is extended fixation. It has got 32% of voting. So what I did was like to be more safer on the side, and I want the implant to be on both sides. So I did. Can you take off this the sharing, vote sharing. Hello, Oscar?
It's off, Jyoti.
Oh, it is not, no, it is there on my finger.
I don't
Anyway,
see it on my screen.
Oh, I'm able to see. I don't know what's happening. Anyway,
You can remove it, Jyoti, yourself.
I'm not able to remove, I'm not able to do that.
You'll find an exit one at the top right corner.
Exit one.
Yeah, but nobody's seeing it. So just,
Oh, yeah. Okay, right. Now, this is what I did a little bit extended occiput and C3 and C4. This patient had got immediate relief from pain. There's no pain, absolutely fine. The patient was comfortable. There was no pain. Sorry, I'm not able to move my slides.
Can you restart the video?
Yes, take off.
Oh, yeah. Now, are you able to see this?
yes.
Yeah, this is how I fixed it. And you can see the bone graft I placed what, like Professor Jaleli was talking, that I put it on C1 and C2 and continue with anti-tuberculous treatment for more than 1 year. We give the first 4 drug regime for the first 6 months and then for nearly about 1 year more with the 2 drugs with rifampicin INH. This patient had a very quite comfortable recovery of pain, and this we published quite long years ago. Now, having said this, I like to mention about these 2 gentlemen. I think probably you're all aware. You may be knowing this, Professor Tully and Professor Moon. Probably during their time, they may not have advised to go in for instrumentation. I was very fortunate to have a lot of conversation with them. I always tell them that if you put the patient on the collar or whatever kind of halo fixations, still it is very cumbersome for the patient. So internal stabilization immediately provide a very good pain relief for these patients. So the pain in tuberculosis has become an indication for surgery in the era. Now, having said this, I would like to show you another case, which is more interesting because of the younger age. She is just 19-year-old girl who had progressive torticollis with severe neck pain, similarly. And you can see the torticollis is so bad. The Robin Cock neck, you can see very rotated. And there is also mild rotation of and C1 and C2, which is also seen in the lateral x-rays. Of course, there is not much of dislocation seen. She had a severe pain, similar case, similar kind of case. And you can imagine this kind of picture we got it. This is the kind of picture we got. Now, this you can see on the right side, the lateral mass of C1 is absolutely not there, eroded completely. And on the left side, you can see that C1 is subluxating on C2. Occiput is okay. And the MRI shows the classical granulation tissues. In this case, I was thinking of putting on one side fixation of C1 and C2, but without including occiput, and I don't think it is possible because the facet, the lateral mass is completely destroyed on the right side. So in one interesting point in tuberculosis is this, that tuberculosis is an ongoing process. It is an ongoing process. It's very difficult to control the ongoing process. It starts from the pus, the granulation, and then the fibrosis, and then constricts, and then deforms. So unless it is reducible at a very early age, it does not reduce. So you may have to do mechanical reduction, which is going to be pretty difficult. It is not that easy. On the MRI also you can see there's not much of dislocation. So in this case, again, I did the same technique. Absolutely. Now I just left C1 and C2 and position the patient. On positioning, what I found was the C1 on positioning. I found the C1 and C2 was reasonably aligned on the left side, but still I did the same thing, like taking the biopsy from the right side lateral mass, and it came as tuberculosis. And then we treated the patient in the same technique. Now you can see the earlier it was discussed, I put lots of bones. The most important thing is that finally we need a good fusion at occiput C1 and C2 because the lateral mass is the bridge between the occiput and C2. When that is gone, then you need a very good fusion. So here the extended fusions were very much useful for two reasons. Number one, it becomes very simplistic. You're not meddling at the C1, you're not meddling at the joints, particularly in tuberculosis. If it is a cold abscess, you open it, the cold abscess pour out. But the granulation tissues, they don't come very easily. It is very difficult also. So this is one of the two cases which I'm just showing, but we have so many other type of cases of tuberculosis. Particularly sometimes we get at occiput and C1 superior facet joint, that occiputo C1 joint, and there you get tuberculosis. So very excellent, but those cases we don't fix it immediately. We just put the collar and they do pretty well. So these are the two cases I like to show it to you and then invite discussion because I've seen very experienced surgeons here. I saw Patrick Kluger's name also. Patrick Kluger is listening, my friend, and Goel is also there.
Very illustrative case of the need of going to C0. Thank you for showing the two cases, and I would like to hear from Mehmet and Atul, their comments on these two cases to start with.
Sorry.
Can I tell you something?
Yes,
actually,
please.
If I were Jyoti's place in the last case, I would do unilateral fixation.
Okay, yeah.
Not the other side.
Absolutely. I was thinking the same. Hello?
Yes.
One second. I'll stop sharing this. I'm not able to. Is that okay? Yeah. Actually, I had the same plan, but I was just thinking about it. Could have done on the C1 and C2 on one side and then put bone graft. But then I really wanted to know how we can address the occiput. Atulji, because C1, C2, we can fix it from one side. But here the complete facet is gone, lateral mass is gone on the right side.
See, the thing is, you know what, tuberculosis, as you know, Jyoti, you have done a lot of work on this. I know your work. Tuberculosis usually involves the facet of C2 first. C2 facet involvement is number one problem in tuberculosis, and then C1 facet. So C1, C2 articulation involvement is the number one involvement in tuberculosis. Occipital condylar involvement is there, but very uncommon, occipital condylar involvement. So what I do is, you know what, first thing, many of the audience may not know that drug treatment is very good for tuberculosis. That is a very important thing, that we can treat many of the tuberculosis by only drugs. But if we require treatment, you know what, as Mehmet said, we can do only on one side very solid fixation on C1, C2 itself. Just C1, C2 solid on one side. As you showed in your second case, the whole thing was, you know, the facet of C1 was completely dislocated. So you could have, you know, that I would have done on one side. Solid fixation is good enough, and give a, you know, kind of a halo brace or collar. That is what I prefer. And drug treatment, of course.
Agreed, Atul. Actually, I was thinking about it. This is actually a very long time ago I did this case. And after that, many cases we did unilateral fixation. I think Professor Jileli knows, in my last presentation, I showed a lot of unilateral fixation for tuberculosis. Just fix it on one side, degranulate on the other side, and a very nice anti-tuberculous treatment, fantastic results. I learned it by doing this, but initially the extents were very long. And the second point was that the early presentation of tuberculosis. Now, if it is at the pus level, when you open it, that you get a pus, it is very good. But if it is more harder, it is very difficult. But this case was reasonably good. I was just thinking, because of this one I presented because of the extended fixation cases series. Yeah.
Can I mention can I make a comment, Jyoti? Very nice cases. I think I always be concerned when you go to occipital C4 construct, not to include at least C1 or C2. You always, I don't try and do that because this destabilizes a bit more and causes more non-union. For the first case, I agree, unilateral C1, C2 may be good enough. For the second case, with the subluxation, and Atul and Meben will probably disagree with me, I would be an ease to leave only unilateral. I try to move bilateral, and there I would probably extend a little bit more, but I try to put C2s in both sides to give more strength to the construction, and also probably decompress C1 to see if I can reduce slightly the lateral mass and put it back in there. Although I think it's going to be extremely difficult.
Okay, Philippe, are you there? Philippe Boncel, can you share your thoughts about this case, Philippe?
Oscar.
Needs to unmute himself.
Philippe, can you unmute yourself?
Yeah, okay, you heard me?
Yes, Philippe.
Yeah, okay, I apologize. Yeah, several comments. First of all, about occipital-cervical junction, the vertebral artery may have a different kind of way, particularly in malformation in rheumatoid arthritis and in infection too. The reason your lesion is just invading the vertebral artery. So did you do any CT angiogram or not? And what about the risk of vertebral artery injuries? This is my first question. And the second question is, as soon you fix the occipital-cervical junction, there is a major risk of wrong angle. And Japanese people just published some kind of complication with respiratory distress just afterward, because sometimes you pull back all the spine and you have some kind of compression of the trachea. So I would like to define the exact angle and how you avoid this kind of complication. Do you hear me?
Yes, sure.
Yeah.
Jyoti or Mehmet or Atul, can you give an answer to Philippe?
Mehmet?
Sorry, I could not capture that nicely.
Same thing. I could not get the question properly. Can you summarize the question quickly, please?
Back. First of all, as soon you fix the occipital-cervical junction, there is a major risk of respiratory distress described by Japanese people. If you don't restore a normal angle between C1, C2, there is a risk of injury of the trachea. So my question is, how do you solve the exact angle, particularly in case of big fixation to the thoracic area, just to avoid this kind of complication? And the second question is, are you doing always an angio CT scan just to know the way of the vertebral artery in Klippel-Feil syndrome and rheumatoid arthritis?
Atul can answer that better than me, probably.
Or Jyoti, please.
Yeah. As far as the second question is concerned, that angiogram is a part of the workup, number one. As far as we are concerned, we do the CT 3D angio, so it goes as a routine for us. But I'm talking about in case of C1, C2 dislocation or assimilation or basilar invasculation. So it goes as a part of the workup, but then actually it is not needed. If you see very good bony anatomy in your regular CT scans, you can always find where the vertebral artery is. But on the first question which you said, how do you do the assessment of the assimilation? It is by anatomical cues, and you also have your image intensifier, and you can always check it up. So I do not know how we misangulate and fix the spine on occiput to cervical spine. I think probably Atul can also talk about it, because The moment you reduce it, it has to come into alignment. When we don't do it, then you go into disalignment, then can cause the compression of cervicomedullary junction. So that is very dangerous.
So I will just like to answer the question which I didn't hear properly, but I'll just like to make some issues regarding vertebral artery. See, vertebral artery is very important to preserve in cases of atlantoaxial fixation. And that is the whole operation. And I actually like to do all kinds of investigation like CT angio, MR angio. I like to do 3D angio, 3D CT scan to see where the vertebral artery is, almost all cases, particularly more complex cases, because that forms the basis of the whole operation. And you know what, my operation has three very important parts. One is to open the joint. Unless you open the joint, you can do nothing. This is my feeling. Remove the cartilage, introduce bone graft in the joint, the whole thing will be aligned if you do this part. And I do the operation under traction, open the joint, remove cartilage, introduce bone graft, and then do screw fixation. And most important is preserve the vertebral artery under any circumstance. You can damage, of course, but you have to aim to preserve.
But Atul, what about the creation of a respiratory problem because of the head position?
No question. You see, if you do under traction and you don't involve the occipital bone, you see, my feeling is occipital bone involvement and long implant can do this kind of respiratory involvement. But if you do focal fixation, C1, C2 solid fixation, there is no question of respiratory issue.
Yes.
Yeah, as short as possible. Yeah.
Yes, Atul, this was the question. And I think we all agree that a single fixation will minimize this. But the question which was raised by Philip was, do you have any trick when you are about or you are convinced you're going to go to the occipital bone to align the head in a way to avoid this distress injury, to avoid the compression of the trachea? If you hyperextend the neck and flex, you will have this problem. How do you have any trick when you position the patient towards protecting this trachea before fixation?
Yeah, you see, this is very important. The position of the patient for C1, C2 fixation is absolutely crucial. You know what? I don't give flexion. I don't give extension. I give the head high. The table is head high, about 30-degree head high, and the head is under traction. So what happens is the patient's face is not even touching. It is almost kind of a floating head. So it is not under flexion, not under extension, but it is in the neutral position kind of thing.
Like this.
Okay.
And then you are not, manipulating anything. And then you are introducing very lateral. It is away from the, I think that is the beautiful, best position. Don't do manipulation, flexion, extension during operation at all in these cases. If you do manipulation, you see under anesthesia, you can create a big problem. Under anesthesia, no manipulation of head. That is my absolute warning.
Exactly.
Thank you.
That's a good point, Atul. I think we need to move on to the next section, which is on when to extend to the thoracic spine. And we have here a crossfire, very good fight between Mike Flavum, living in Newark. He's assistant professor of orthopedic surgery at Seton Hall University. And the opponent will be Asdrubal Falavinha from Brazil, director of Health Science Center and at the Hospital of the University of Caxias do Sul, and is the chair-elected AO Spine International Board. So we have two distinguished professors to tell us where to extend, whether or not to extend the thoracic spine. Please go ahead, Mike.
Okay. So thank you, Oscar. Let me just share my screen here. And for my my opponent, Asdrubal, muito prazer. Let me share the screen. Okay. So again, thank you to Oscar. And, you know, the topic is, I'm going to defend the stopping at the cervical portion of the junction at the C6, 7 levels. And as a part of my disclosures, I probably should have included there that the majority of my practice, I actually go to T1. But this is usually the case that when I get invited to speak by Oscar, I end up being thrown into the position of some kind of scapegoat and sacrificial lamb. So I'm quite used to it. These are not the first time that I've used these slides with Oscar. So by at least starting with the fact that in a majority of time that I do go to T1, when I started to look back at the list, I actually became a little more confident in being able to defend C7. So starting off with the fact that patients with long fusions intrinsically are difficult to assess in terms of what their outcomes and radiographic outcomes are. We have patients with expected pain because they have multi-level arthritis. Many times there's deformity. We expect that they have some kind of neurologic finding, and many of them won't even improve. And then they also have you know, pain generators that are present after we fuse them. We have muscles that can't move. We have stiffness. We have unfused disc. But looking at the literature that surrounds the outcomes from early on, mostly we've had descriptions of people's techniques, and then we have looking at the perioperative outcomes of who's at risk for prolonged intubation, how much blood loss. And I don't think there's going to be much of an argument that stopping at C6 or C7 in terms of perioperative time, blood loss, and those kinds of risks are intrinsically common sense. You're going to have a shorter surgery. You're going to have less of those perioperative findings. But I've broken it down into, you know, the complications, or at least the outcomes we need to be looking at fall into plus or minus these categories. And many of these categories seem to overlap. And that's difficult because when we start to do our statistics, you ask, well, who's falling into what category? And many, if all, the research that's been done on alignment and balance or adjacent segment degeneration, pseudoarthrosis, or instrumentation failure has really only been done within the last 10 years. So what is really important is defining what are we looking for with the population itself and its outcomes. And I think we really need to focus this slide that the majority of the patients that we're talking about right now are multi-level spondylosis. Those are the overwhelming majority. This is a proportional slide, I think, and I don't even have good studies to give you the numbers on what that proportion is. But we have to be careful when we start to include the complications that come with the deformity, the iatrogenic complications, rheumatoid arthritis, and trauma. We need to keep those in their own category, because work has been done that does show that instability at the cervical thoracic junction, whether it's a revision surgery, post-laminectomy kyphosis, or deformity correction, even the risk of patients just with smoking alone, we're all going to agree that you probably shouldn't stop there. So this is a list of publications that have come out within the last 5 years that are all attempting to look at this. And I think the most important, I'm not going to knock any of these. These are great groups with great research abilities, but I'm going to take the top 4 and look at where there's a lot of problems with this, because I think if you look at the most important picture on this slide, it's that bowl of apples, oranges, and bananas. And unfortunately, the bananas are being thrown in with too round fruit, and it's kind of just trying to exemplify where we're not identifying the proper population and we're not trying to look for the right things. So I look back at lumbosacral long fusions is, in my mind, something that does have a very long track of good data, good studies looking at these techniques. And when we start to break it down into the cervical thoracic junction, many of the descriptions that we have and findings are contradictory to what this data is. Most of the time when we talk about fusing across the lumbosacral junction, that's when we start to talk about pseudoarthrosis. So my question is why, when moving from the mobile cervical spine into the thoracic spine, that we find that pseudoarthrosis occurs when we terminate at C7? that doesn't make sense. Now, to really make everybody feel old, you know, this is, I think, one of the landmark studies. And unfortunately, it's a landmark study that we have to describe from last century, being in 1999. And this is the Bowman and Hillebrand study. And they had great decade-long follow-up adjacent segment degeneration. They had great data that looked across multiple segments. And this is one of the papers that we all look to. Well, when we look at their specific data that starts to get into adjacent segment degeneration, they found a very, very, very low risk at the cervical thoracic junction for adjacent segment degeneration over 10 years. This is where I leave behind any argument of the C6-7 disc being at risk for adjacent segment degeneration, because I think we know that it is. It's in a mobile area and it gets close to a very transitional area. I think the numbers that they had actually show that pretty well. You know, having numbers pushing 200 levels, this is data that we just can't forget and turn our backs on. This is a very good premise to start with. So when I start to look at the papers that have been published recently that are, again, over 200 patients, and this is a great group from Jefferson. We all know the names. They describe out of 200 patients, 61 revisions. But when we look at what reasons that they knew the revisions occur, they only had that available for 24 patients. That's not even 1/3, or it's close to 1/3 of the reasons for revisions were available for analysis. So that tells me, who do I believe and what do I do with that data? Because in my mind, the revisions are quite variable and the reasons are quite variable for those revisions. And then when we look at how they broke it down and the conclusions that they made, they separated C7 and T1, and then for some reason, 30 patients in the T2 to T4 category were excluded from T1. But if you look at the revision rate between those, which is, again, the last key point here, the second key point, is that those T2 to T4 patients had a 40% revision rate, which is greater than the C7 patients. So why weren't they included in the thoracic junction category? And then if you look at the last sentence of the conclusion, it says that there was no difference between stopping at T1 and T4 to T2, but meanwhile, you got more than double the revision rate. So that's getting into the statistics, and I don't think it's my job to check that out, but I don't think that's a very good conclusion. I think that there's a large trend when you have a revision rate that's even higher than the C7 revision rate. I don't think you can come to any kind of logical conclusion. So again, I don't know what to believe. This is a paper from Neurosurgery. This is the Georgetown group. And they had 149 patients. They had 15 revisions. And the main table that looks at the revisions, overwhelmingly, C6 is the quote unquote stopping at the cervical thoracic junction, which has a revision rate of 8.3. And then for some reason, if you look within that circle, C7 with 1 revision and T1 with 1 revision, C7 has a 5.3% revision rate and T1 has a 2.6% revision rate. So I don't know if that's the editors, but I don't know how that lets you come to the conclusion, which is below, that stopping at the thoracic junction leads to a higher revision rate, because that is clearly wrong. I think this is another great study from a great group. And very involved in the topic. And when they looked at all of their outcomes, again, a group of close to 200 patients, they report similar clinical and radiographic outcomes. The only difference was that pseudoarthrosis rate that I talked about and the EBL OR time, length of stay, et cetera, which again go back to the clinicals. Now, going down to some conclusions that if you read the finer lines within that, the revision rate was not statistically significant between the two, and the pseudoarthroses that occurred were 53% smokers. That, again, is, to me, apples, oranges, and bananas. So the other thing is pseudoarthrosis, to me, does not equal revision or surgery. If it's a stable pseudoarthrosis, then we don't need to throw it in there. And so, again, what outcomes are we looking at? This is another great group from Johns Hopkins, and this is, again, one of the top 4 papers that we have on the topic. And if you look at their numbers, 168 patients, T1 had 109 stop, all of them posterior, some of them with anterior column support. But when you look at the comparisons, they're looking against C7, which has 59 patients. And of those, more than half, or close to half, not more than half, but very close to half, are anterior cervical discectomy and fusion. They're not posterior cervical stopping. And so when they broke it down by who was actually revised, now more than half of them were anterior cervical discectomy and fusions. So how can we come to the conclusion that there's an increased revision rate? When you look further into their study, they talk about, again, the same thing with outcomes of estimated blood loss, operative time, length of stay. But the bottom line is that in all of the patient categories or patient outcome studies, there's no difference. Now, maybe those outcome studies are inadequate, but we really have just failed to show the difference. The reason why I felt more comfortable about this, and I started to really question a lot of this stuff, is we presented this data in NASS in 2015, and unfortunately, I've had a series of fellows that haven't finished up the paper itself, to the point where I just got to sit down and do this. As we looked at approach to the cervical thoracic junction back in 2015, again, we don't have the greatest of numbers, but I think it falls within the similar category of all these other studies, is that we compared multi-level ACDF to multi-level posterior cervical stopping at C7 and then T1, T2. There is radiographic differences with anterior column support. I think that's something that we would all anticipate. But when it came down to complications, and we saw this back then, is that we really didn't re-operate on people very much. And this is excluding infections. This is excluding early postoperative washouts, et cetera. We all know that there's going to be wound complications. Our conclusions that we came up in that study was that the only case that we actually revised for pseudoarthrosis was actually crossing the cervical thoracic junction. I'm about to show it. And then at the bottom there, clinically relevant complications and the rates leading to reoperation for long cervical cases were not really that high in any category. Here's an example of why I would say what category to put people into. The preoperative picture on the left is someone undergoing revision surgery. They were fused down to C7. They then progressively kyphosed. They underwent a fusion to C7 and then ultimately had to undergo revision from C2 to T2. My point to you would be is what category do I put this person in? When we do these long studies and we try and get our numbers up, is he an adjacent segment degeneration? Is he a revision? Is he a kyphosis? Is he a deformity? This is something that is an apple that needs to be looked at individually. Here's T1. This is the neutral alignment. This is a patient who underwent long fusion for multi-level stenosis, and he's fused, again, from C2 down to T1. I would point out that this is the only pseudoarthrosis. You still see the joint. You can argue technique. You can argue whatever it is. But look at the size of that disc anteriorly. Ultimately, after his pseudoarthrosis, he needed to be revised from an anterior perspective. And so that comes down to, is that technique, and how do we fit that into the one or two patients that are going to be that complication and revision rate? Here's another example of a patient who's also down to across the cervical thoracic junction. They develop proximal junctional kyphosis. Does that have anything to do with the posterior aspect, or should they have had an ACDF? Is it because of rigid without rigid fixation proximally compared to distally? And then how does this patient get categorized? Are they categorized as PJK? Are they categorized as lack of fixation? Or do we need to start breaking down again anterior, posterior? So to really summarize everything, overall the revision rates are low. I think that our literature populations are very inconsistent, even for meta-analysis. When I was considering throwing all of these papers together, I don't even know if there's a consistency there. Bottom line is the clinical and radiographic outlines are compatible or comparable, and few of the outcomes looked at are consistent. So moving forward and saying which one is better and which one is worse, I think we need to identify when and what. So what outcomes are we talking about? When are we talking about them? Because our revisions really are anecdotal evidence. And to bring up what I think is an important point is this is where database studies become very dangerous, because the particulars of that instance of failure and that need for revision gets lost when I don't know who the patient is and they're just entered into a system by maybe a fellow or a resident or even of a lower training. What category did they get thrown into? So we need to identify better variables and get that into the literature. been a lack of consistency of both the population and the findings. Thank you.
So, thank you. We have some questions here. Just a question, actually. Based on clinical studies, which of the following benefits to terminate a long cervical fusion at C7? So please, you can vote. So Mike, thank you for this very nice critical evaluation of the literature. I can only ask such a difficult task to a tough Irish guy. And you did it very nice. I really like your talk. And allow a couple more seconds for people to vote.
Michael, I think you've demonstrated that the literature, in fact, sometimes is very, very bad in this because they're mixing peaches and apples, as you say. And I think unless we have thorough research or thorough papers related to what we want to know, as you say, we will not find an answer for this. I think many people try to cover the anterior pseudoarthrosis from the back. Some of them go from the front. Nobody knows who is what's the right thing to do. And this is a very good criticism that you've made. And I think everyone has taken this into serious opinion. Thank you, Oscar.
Mike, can you comment on the results, please?
Yeah, I mean, so
a little bit more than also the people say that decrease pseudoarthrosis rate. I think you were quite convincing, but the right answer was decrease the wear time, right?
Yes, I mean, really the only clinical outcome that we've really been able to show is that, and I think it's kind of common sense. If you're going to go make a longer surgery, you're going to have a longer OR time. All of the studies are pretty contradictory as to pseudoarthrosis.
Okay. So
I have a comment if you agree. Yeah, Mike, I agree with you. We don't compare things. I mean, as soon you're doing a big fixation and you don't, you don't have a look on the sagittal balance. You show us a case with an SVA very high. So it's evidence as soon you get down and you left a big arm level, you'll develop, like in scoliosis, like in kyphosis, you'll develop. So when you talk about long fixation and a junctional problem, it's depending on what you're talking about. It's just a fixation, it's not a problem. This is a sagittal balance who can play a major role in the imbalance afterward. And I agree with you when you saw the case with the fixation stopped at C7 or C6, and due to the fact that it was still in imbalance, the imbalance is just increasing. It's not a problem of fixation, it's a problem of understanding the deformity. So I agree with you. Okay, so we have the other opinion that will be discussed by Asdrubal. Asdrubal basically is analyzing the literature and telling us when you should really extend to T1 or T2. Please go ahead, Asdrubal. It's okay. Asdrubal, please go ahead. Yeah. Just you listen me? Yeah, just on full screen, please. Yeah, it's going on. Okay. So yeah, fine, excellent. Thank you. Thank you, Oscar, for the invitation. My name is Asdrubal Flavum. I'm a neurosurgeon from Brazil. I'd like to present my city. My city is Caxias do Sul. It's located at south of Brazil. My state has bordered with Uruguay and Argentina. If you like a good food and wine, please, you are very welcome to come. I have no conflict of interest with this talk, and I will describe the influence of adjacent segment of disease on the cervical spine, highlight the importance of achieving the cervical spine alignment, and to review the publications
in PubMed, as Michael recently approached. The cervical spine promotes the alignment of the head over the pelvis, support the head, allow a horizontal gaze, and wide range of motion. It's always nice for us to keep this in mind. Hillebrand described 25% of newly developed symptomatic ACD within 10 years after anterior fusion. We have to understand that the number increased 3 times after posterior fusion. And this increase is secondary muscle weakness after a posterior approach and the incapacity to provide anterior support or gain or maintain lordosis. So the posterior approach by itself can cause more adjacent disease. Spine surgeons have experienced the need for revision surgery for adjacent disease in which C7 is the lowest instrument vertebra. And extending the arthrodesis to the rigid thoracic spine will be able to protect them. We are aware about the importance to achieve or maintain the harmony of the curves. And this is very important in order to protect development of the adjacent segment pathology and at the same time to provide the best chance for a favorable clinical outcome in both cervical or thoracolumbar deformity. So the goals of the cervical spine surgery are not only the decompression, but also to achieve the normal values of the cervical numbers. There's a strong correlation between cervical spine parameters and functional outcome in patients with deformity. So restore the cervical spine parameters. It's one of the main goals of any type of surgery. And that's the reason why surgeons commonly recommend stent cervical fusion into the thoracic spine. Let's take a look into the literature. This paper is a systematic review and meta-analysis done in 2019, and 6 papers were selected. 5 were retrospective, 2 were one-arm studies, and 4 were comparative studies. Some had a smaller sample size, and the mean follow-up was between 2 and 3 years. And this is the main what caused all the heterogeneity that Michael was discussing in the previous lecture. The author focused on hard outcomes, such as fusion rates and reoperation, because the information can easily be retrieved retrospectively on the database. And the sample size is around 530 patients. So the conclusion was that crossing the cervical-thoracic junction may have higher fusion rates and lower reoperation rates. And that was a systematic review in 2019. So many limitations, study limitations, were observed due to the retrospective design of the study. So we have the lack of description of the surgeon decision to stop at C7 and thoracic spine, heterogeneous patient population, pathology and surgical technique. Sometimes we have a mixing approach and the lack of patients' comorbidities. So that was really important when you're trying to find variables that make you decide from stopping C7 or T1. I performed a PubMed review to find the papers that were not included in the previous systematic review, hoping to have a reliable information from study level 1 and level 2. And I found 5 articles. 3 articles were published in 2019 and was not included in the previous systematic review, and 2 articles were published in 2020. So if you look those articles, all of them were retrospective studies. A follow-up keeps between 2 and 3 years, and 2 papers had a smaller sample size, 46 and 79. So if I select the different type of outcomes and I display in columns, the table was highlighted in black if the comparative results between stopping at C7 and T1 were similar, in red when there was a difference in favor of C7, and green if there was a superiority of T1. So we can look from functional outcome is pretty much similar, those papers. As Michael already reported, longer surgical outcome and higher blood loss is presented mainly in favor of C7. But if you discuss about fusion rate, reoperations rates, we're gonna see more green color than red color, because it's where T1, every time you go to cervical thoracic junction, you're gonna have more fusion rate, and you can restore the radiographic parameters. The complication rate is much similar. You just change one complications from other. T1 is more common, skin problem and infection, and C7 hardware complications and adjuvant disease. But at the end, the study limitations from those 5 papers was very similar from study limitation from systematic review. That means that we need another prospective study to solve that problem. So some variables was difficult to analyze in this review. The role of specific cervical parameters, the different types of C7 screw fixation, lateral mass versus pedicle screw, the lack of individual patient data, the functional impact, we cannot have the answer about functional impact and stopping C7 or T1, and some specific operative technique that we know that make a lot of difference. So as take-home message, crossing the cervical thoracic junction increase the morbidity, but is necessary in selected patients, that those patients predisposed to adjuvant disease, pseudoarthrosis, hardware failure, that was osteoporosis, patient, smoker, insatisfactory proximal screw purchase, arthropathy, C7-T1 disc degeneration, and those patients that we need sagittal balance correction. So some strategies to prevent this problem is choose right your level, your selection level, and minimize the damage of the muscle and the ligaments. At the end, we need to individualize the treatment approach. It's not the same tools for all patients. And we need to shift from how to treat to whom to treat. And this is like, now we understand that we have the opportunity to start like a prospective study and have the right answers for our questions. So at the end, we have these 2 questions that I think that Oscar wanna have on the screen.
I'm going to submit so thank you, Asdrubal, really wonderful, wonderful lecture. I really thank you. It's an honor for us that you showed your original research here with us. And I'm very proud of that. Thank you so much. So the questions are, what is the main factor to be considered in deciding whether to cross the cervical thoracic junction in multi-level degenerative cervical stenosis? Patient age, bone quality, or cervical radiology. Select the true answer regarding extension to thoracic spine in multi-level degenerative cervical stenosis patient. Stopping long and short fusion at C7 accelerates adjacent segment disease. Extension of a posterior cervical fusion into the thoracic spine leads to a lower pseudoarthrosis rate. crossing the junction may increase surgical time and estimated blood loss while reducing the risk of wound complication. And there are reasons to justify a prospective and controlled trial study. Just allow a couple more seconds for people to vote. Okay, going to share the results. Do you want to comment, Zdruwal?
Yeah, the first question, I understand the impact of bone quality in our planning about to stop in C7-T1, but for me, the cervical radiological, if I have a patient with deformity, I'm quite sure that I'm going to the thoracic spine, much more than bone quality. If I have an older patient with select compression, I rather prefer to stop C6 or C7 if I can to. But if I have a deformity patient, I usually go to T1 or more or less I go to T2 or T3. And the second question, the correct answer is the D, is we need to have a prospective study with all control the variables and some type of randomization in order to have more homogeneous patient and homogeneous treatment. Otherwise, we're gonna discuss this all day long and we're gonna have any answers.
Okay, Zdruwal, very nice. I have a question for Mike and Zdruwal before giving the microphone to Onur Yaman from Turkey. But my question is, do you include in your decision process, sagittal parameters like SVA, like T1 slope, increase SVA, vertical T1 slope? Would this be a good indication to extend to thoracic spine or not, if it is the opposite? Mike and Zdruwal.
As I said, I include the SVA, I include the cervical lordosis, the T1 slope. It's very important. For me, to finish the surgery with a good cervical balance, for me, it's along with the decompression, is both my goals of the surgery.
Yeah, I mean, Oscar, I don't think this was a very contentious argument here. I think we were almost in agreement with the entirety of our patients that it's really the failures that occur with the particular cases. And to answer the question of, do I include, I think SVA is very important. I think taking the radiographic in practical use and where it does really fall into it is that radiographically you assess where you get your correction, if there needs to be correction, and then you have to decide whether or not there needs to be or how much aggression. But answers sometimes do occur, I think, on the operating room table when you're positioning your patient. And I always take positioning radiographs before the fusion occurs or before the procedure.
Okay, Onur from Turkey, can you come forward and make a comment?
Can you hear me?
Yes, please, Onur. Just show yourself. Yes, Onur. Hi.
Oscar, how are you?
Good.
Oscar and La Fuente, thank you so much for organizing this excellent meeting. We heard really excellent presentations from Zdruwal and Michael. The things that I can say about the question is, I think, where we have to stop at C7 or T1 is the same question, I think. Do we have to stop at L5 or S1? It's the same. First of all, we have to know that T1 is the sacrum of cervical spine. I'm repeating it. T1 is the sacrum of cervical spine because T1 is changing in time. So if we cannot realign the cervical sagittal balance, the question is, I think, is not stopping at it's C7 or at T1. If you can realign the cervical balance, it doesn't matter if you stop at C7 or at T1. if T1 is the sacrum of the cervical sagittal, then we're talking about how can we strengthen the S1 screws. So we say that we have to put an anterior device, or we have to go to C2, or we have to go to the iliac mix there. The question is that if we go to T1, we have to do something different. So maybe we have to put an anterior, maybe C7 to T1, an anterior device there, anterior support, or we have to go to T2. But if you cannot realign the cervical balance there, it doesn't matter if you go to C7 or T1. And another parameter at the cervical spine is that the C0 and C2 is inversely changing the cervical spine. If C2 and C7 has decreasing, the C0, C2 is increasing. If it's C0, C2 is decreasing, C2 and C7 lordosis is increasing. So the main parameter is here, you have to realign C2, C7, SPA, you have to realign the cervical sagittal balance there. If you can do everything, another parameter that we have to consider there is what we have to do at C0, C2. And another question here. We're measuring the cervical thoracic, thoracal kyphosis from T4 to T12. Doesn't matter there if between the kyphosis at T1 and T4. This is the main question, I think. Because we know that there is a 8 degrees kyphosis between T1 and T4. But nobody is talking that. But there's something missing there. So maybe my question will be to Bensel from, I think, how are you? So the question is that.
I agree. I agree with you. Sagittal balance is very important. You summarize all the problem, and getting down to C1 or C2 to C7 or C. It's depending on if you have still an imbalance. And Eiko Koller was concerned about that. He proposed to get down to T1, T2, T3, T4. Why? Because he's treating a lot of deformity. And as soon you are still a deformity, everything is still increasing in sagittal imbalance. So there has been demonstrated every time. You correct the deformity, but enough, not enough in lumbar area, for instance, and everything is getting down. And like Jean Dubousset told us a long time ago, I agree totally what we said. Perfect.
Another question is that we know lots of things about the global sagittal balance. We know that exactly the pelvic incidence minus lumbar loadings has to be less than 10 degrees. But we don't know the same parameters cervicals. We don't know how the T1 slope. We know that if it's less than 20 degrees, it's fine. But we don't know the difference, the exact difference between this T1 and cervical lordosis.
Very good, Honor. Excellent.
Excellent. Yeah. Thank you very much.
Thank you so much. Mike and Asdrubal, any brief comments before we go to the clinical cases?
Yeah, I wanted to that I think, one of the points of my presentation was a lot of the early work and a lot of these techniques, that of the procedures that are intrinsic to the procedures that we do are kind of built into the procedures and were never really described in terms of the outcomes of chasing parameters. I mean, a lot of times of all those patients of my series of the 200 patients, the majority of those patients are put on the table and eyeball, and the revision rate's very low. So I just think we need to identify when we're chasing or what's built into that, because it just hasn't been written. And I just am very wary about, again, of those 200 patients, I don't know that I ever checked T1, this, that, or the other thing. And the revision is low. So we need to find out when it matters and when it doesn't, because the majority of the time it actually doesn't matter.
Thank you. Thank you. Okay. I think we go now for the clinical cases. And I was supposed to present next, but I can do at the end. And I will ask Osam Salah from Cairo. He's head of spine department at Nasser Institute, professor of orthopedic and spine surgery at Cairo University. He was the founding member of Egyptian Spine Association, and he's very, very experienced surgeon, very knowledgeable, and he will present here quite a, challenging case, maybe opposite to what we are saying here. Thank you, Osam.
Thank you very much, Oscar. Good evening, everyone. Thank you for the kind words that I'm not worthy at all. Thank you for the invitation. I'm very happy to be here. Well, let's not waste any time. I have no disclosures. This is a 42-year-old lady that I saw back in 2008, presenting with quadriparesis, inability to walk, a frank case of severe myelopathy, cervical myelopathy affecting both upper and lower limbs. She had 3 previous surgeries in 3 different countries, and she had no real improvement after these surgeries. And that is her plain x-rays. Nothing much to see. You can see that there has been an attempt of doing something posteriorly. Some of the spinous processes are taken away. The plain x-rays I couldn't find, except these long x-rays. Doesn't show the cervical spine, but at least shows us that she has a reasonable thoracic and lumbar spine alignments. This is the MRI scan, the sagittal cuts in T2. You can see here, if you follow my arrow, this thick line of black tissue compressing the spinal cord severely, starting from the C3 level down to the T6. It also stays dark on T1 weighted images. On the axial cuts, you can see still attempts at laminotomies at the 3 previous operations, but still there is this very thick tissue, and still black on T1 and black on T2 on the axial cuts. And the thoracic spine, the same thing on T1, you can see that. And again, a close-up here to show you the dark tissue that's present behind the spinal cord and compressing it severely. With contrast, no enhancement with the contrast compared to T1. So there is no enhancement of this tissue, stays darkly with the same level of darkness. This is a sagittal cut of the CT scan of the whole spine. And again, I'm just showing this to show you the reasonable alignment and the effects at the top here of the previous operations. This is a CT with the axial cuts, laminotomies. You can see the soft tissue, no calcification along this black line. It's soft tissue, ligamentous structure at the behind, severely compressing the cord. So basically, question 1, what is the possible diagnosis? Can we launch the voting, please, Oscar? Yes, thank you. Is it a degenerative or a congenital stenosis or a hypertrophy of the yellow ligaments? Or is it an aborted form of ossification of the yellow ligaments? Or maybe we don't know. I mean, I honestly didn't know exactly what this is when I first saw it. Can we start voting?
We could also vote for the next question, no?
Okay, sure.
I don't think it's working, the voting system.
So what's decompression alone?
Yes.
Decompression plus instrumented fusion from C3 to T7.
Yes.
Decompression and instrumented fusion C3 to T10, or fusion to C2 T12.
Can we start voting on the second question?
Yes.
We cannot submit it.
Yes.
I cannot.
Most of the, I think all of us, because we are co-hosts.
Most co-hosts cannot vote.
Cannot vote.
Okay, fair enough.
Okay, so These are the results, Hussam.
Yes. So it is a hypertrophy of the ligament. 40% thought that. I think that is a reasonable diagnosis. That is the diagnosis. Which maybe like it is a hypertrophy, but like an aborted form of the ossification of the yellow ligaments. And regarding the second question, no real voting has been done. But anyway, yes, there is voting, sorry. The majority, 35%, decided to decompress and fuse from C3 to T10. Almost equal number C3 to T7 with fusion, and less, almost 20% thought of decompression only.
Okay, so show us what you've done.
Okay, so this is my rationale at that time, 2008, was this is a compressive cervical thoracic myelopathy. It definitely needs decompression. The question was to fuse or not. I decided not to because I thought after 3 previous surgeries, there was still a reasonable alignment as shown on the x-rays and on the sagittal CT. There was no major element of neck pain. And when I looked at the literature, the lessons learned from the OIL that looks similar to this, that fusion was commonly not necessary. And because the surgery would be difficult, lengthy enough, didn't want to do a long instrumented fusion because of that. So the surgery was a posterior decompression, C3 to T6, identified the healthy looking dura at the top and bottom, as we would normally do. We started removing the ligament, blunt and sharp dissection, and it was adherent to the dura, so we had to like peel it off at multiple layers, no instrumentation, and obviously we had multiple dural tears because of the adherence to the dura, and this required repair with synthetic dural grafts and insertion of a lumbar drain. This is some intraoperative photographs. You can see here the peeled ligaments at multiple areas. You can see here the dura and the arachnoid exposed after the laceration of the dura. You can see here also the thoracic spine, the cord here exposed, the dura exposed, and the long strips of this ligamentous structure, the yellow ligaments, very thick and obstructing the canal. This is the post-op MRI taken a few days after the surgery, the CT as well. It shows an adequate decompression, and it shows here also the removal of this black line. If you compare the pre-op tissue that was occupying the canal here, it's completely gone. A year and a month after the surgery, the patient was back walking with spasticity. She was able to use her hands. She was happy. She had some neck and parascapular pain, and I thought this was a successful surgery. Now, looking at the x-rays and looking at what we use nowadays, I certainly didn't use these measurements 12 years ago. If you look at the C2 C7 SVA line and the distance from the top of the C7 posterior corner, and also if you look at the, I couldn't see here the T1, so I actually did the C7 slope instead of T1, which is a reflection of the T1 slope. You can see a progression, progressively increasing 2005 to 2014 from left to right. You can see the progression of the sagittal malalignment and the translation forwards and the increasing distance of the SVA to the C7 posterior corner, and also an increase in the C7 and therefore the T1 slope as well. So diseases of the ligamentum flavum, I couldn't find really a hypertrophy of the yellow ligament as a topic. I've seen hypertrophy as part of degenerative stenosis, but nothing like that. And also ossification of the yellow ligament or a ligamentum flavum cyst or even a hematoma. A review of the literature that I looked at and was actually quite comprehensive was the one done by Hirabayashi of Japan, published in Spine Surgery Rated Research about the ossification of the yellow ligaments. And it divided the pathology into 2 types: the ossification, where an endochondral ossification happens, and this is the one that more likely happens at the lower thoracic spine, and another one which is a calcification without trabecular structure in the lordotic parts of the spine. The conclusions were of this review article, but that ossification of the ligamentum flavum is one presentation of the systemic ossification trait of ligaments, and is combined and associated with the OPLL, something that I have become seeing more frequently nowadays in the Middle East, by the way. So this is no more a disease of the Asia Pacific or of Japan only, but it's also coming to the Middle East, and I'm sure in Europe and the US as well. CT and MRI is important, of course, to identify the ossification or the calcification, and a static rather than a dynamic element of compression is common with the ossification, and therefore that's why it is commonly not recommended to do a fusion, because it's more of a static compression. And it's suggested that early surgical treatment is important and strongly recommended, and that no complete neurological recovery commonly happens, but rather patients continue with numbness and a spastic gait, which is exactly what we had with this particular patient. So basically, my take-home message is this is a very rare case of possible hypertrophy of the yellow ligaments. Decompression obtained the neurological improvement, and we have documented here a progression of the cervical spine deformity noted on x-rays, something that we didn't look at the same way we're looking at now. Definitely instrumented fusion would probably should have been added. The problem would we stop at the T7, which is the apex of the thoracic kyphosis, or go lower down, and would you stop at C3 or to go into C2, and also the possibilities of adjacent segment disease. I thank you for your attention.
Thank you, Sam. Very, very interesting case. It seems that we don't need to do instrumentation all the time. Congratulations, nice case.
Thank you, Oscar.
And I would like to hear some comments. I see some people in the audience. Adrian Casey from London, Geronimo Milano from Brazil. Can you come forward and make a comment?
Yeah. Hi. Are you listening to me?
Yes.
Geronimo speaking.
Yes.
Thank you again. I have just sent a question at the chat, but the point I think Hassam have already answered. My question would be, if he has have a similar case today, would he do something different? Thinking about the progressive deformity that the patient developed. I think it's a very different and atypical case, so it's difficult to decide. But thinking again about the sagittal malalignment, would you do something different? Would you fuse this patient if you see a similar case right now? Thank you again.
Thank you, Geronimo, for the question. I think that's an open question. I think, looking at what the progress has been with the deformity, luckily she continues to do well. 12 years after her surgery, I had a phone conversation. She's a Libyan patient that I operated on in Libya 12 years ago. She continues to do well from the neurological point of view. Having said that, with the progression of the deformity, maybe I would probably consider doing a fusion. But the question, this would be like C3 to T10. I would definitely stop at the apex of thoracic kyphosis. And if I go to C3, I would worry of having a collapse at C2-3 and adjacent segment disease. So I probably discuss it with the patient and tell her this is the pros and cons of that, and come up with a decision and involve her in the decision, basically.
Very good.
Yeah.
Yes.
I thank Dr. Hossam.
Please.
Yeah. I thank Dr. Hossam Salah for very nice presentation. Especially he has presented in many years long, and the balance is getting worse. First of all, I would call this case as a ossification of yellow ligament, not hypertrophy. This is quite rare, but it happens sometimes. We see some patients. If I was now, probably Dr. Salah is thinking the same thing. He would probably make in our current knowledge, make a fusion surgery from the beginning, because in the cervical thoracic junction, such long laminectomies would end with some sort of post-laminectomy kyphosis. It's well-known phenomenon. There are only cases if the patients are in very old ages. You can not to keep making some sort of fixations, because there are already some spontaneous fusions at the spine.
Yes.
But in the mid-age patients, in 40s, 50s, even 60s, it's better to make some fusion surgery.
Sure, I agree with you, Dr. Zalili. Thank you for the comments, and I definitely agree with you. The thing is, at the time, as I told you, our assessment of cervical, at least my assessment of cervical alignment, was different than what we are looking at today.
Right.
But again, this is a good thing because it shows you over a period of 9 years how there has been progression. And there was also progression at the time I saw her at 2008 compared to 2005. If I had the measurements that we are using now, I would have probably advised her to have fusion after discussing with her the pros and cons.
Yeah,
yes, a fantastic case, Haram, because I recently had one similar from C4 to T2. And I had the same thinking as you did. Sometimes you take some of the ligament from the middle away, you decompress, but some of the ligament is left on the sides, and you think this might hold on to the curve. And I think it's reasonable, particularly your case, after 14 years, you said 12 years with the patient, with these de-aligned but no clinical symptoms, which is for me a satisfactory results, because we don't know what would have happened to this patient if you had fused her from C2 to T10. So you would have probably encountered another problems, particularly with CSF leakage and a pseudomeningocele, which you could see on the CT scan post-op. So I think still that having the curve that you have initially and having an ossification, as Mehmet rightly points out, not hypertrophy, I think ossification also can give you some stability on the sidelines, not in the midline, and you remove the midline, which gives you space for the spinal cord. So I would have, in fact, I did exactly what you did. I did a laminectomy alone. I felt that there wasn't much mobility on the spine, so I thought, and the patient was 68 years of age, so I decided to go there. I may have to go back again, and I will do that if I have to, but at the moment we are not treating x-rays, we're treating patients with symptoms. And if, of course, he had continuous pain or fatigue, muscular pain, you should have go and fuse later at a later stage. But 12 years, if you ask me, do you want to be without operation 12 years or maybe longer, or you want to have the screws put in, I will probably wait for another 12 years. You don't know what happens in 12 years' time.
Awesome.
Yeah,
really,
thank you very much. Yeah.
really.
Just one comment, please, before you ask Oscar.
Yeah.
I mean, I thought this was like an aborted form of OIL. I agree, but I have to tell you, there was absolutely no calcification or ossification in the tissue that I removed from the canal. And if you look at the pathology, what is described for ossification, the OIL or the OHL, if you like, or the ossification of the yellow ligaments, there is nothing to tell you that there is hypertrophy. And to be quite honest, if we have seen a number, this is the only case I have had like this in my life so far. I'm 55, so I've been in practice for quite some time. I mean, if we have like a number of cases like this, we need to publish this because these are very rare cases. And I wouldn't put them exactly like OIL because there was absolutely no calcification or ossification at all.
Well, in mine was calcified.
Yeah.
Awesome. This is really a great case that illustrates how we shift our understanding of the spine surgery, actually. But still, as we see here, the dilemma persists. And just a final question for this case from Onur, then we move to Andre. Onur, please.
Awesome. Thank you so much for this case.
My pleasure, Onur.
At the beginning of this case, I think this case was a deformity case. If you look at the case at the beginning, you said that, and you're right, the patient has a reasonable cervical alignment, but the patient was not having a cervical sagittal balance. The C2, C7 SPA was too high, and in time it increased. Maybe now if you see this patient, at the beginning you have to try to realign the spine, maybe with using ponteosteotomies maybe with using a 540 degrees anterior, posterior, anterior surgery. If you had done the surgery as a deformity case, this case would not progress in time. Thank you so much for that case.
Okay.
Well, thank you very much, Ador. Thank you for your comments. I agree. I mean, again, at the time in 2008, I don't know if these were published yet, the measurements we're using now, but at the time I was looking at the overall alignment. I've shown you the long x-rays of the thoracic and lumbar spine, the CT of the cervical thoracic area. Thank you, my dear. Was okay, but again, when we retrospectively look at it now, even at 2008 compared to 2005, there was an SVA over 40 millimeters, and there was a progression of the slope of C7. I agree 100%. Thank you.
Thank you. We need to move on. I call Andrzej Maciejczak. He's professor and head of neurosurgery at Tarnow, Poland. He's chair of Polish AO Spine and international faculty for ANS and AO Spine. And besides that, we are really good friends and fellows from 96, 97 in Glasgow. We are getting old, Andrzej. Please show us your case, which I think it's a bit the opposite of Osam's case.
Okay, can you hear me?
Yes, please.
Can you see my first slide?
No, we don't see your slides yet, Andrzej.
Okay, let me share my screen. Hold on. And now, can you
yes,
see my slide?
Perfect.
First slide, yes. That's
Perfect.
Great. Hold on.
Please go ahead.
Okay, good evening. I'm very glad to be here among such an outstanding faculty, and I'm pleased to present to you a case of an iatrogenic postlaminectomy cervical kyphosis in a 9-year-old boy with a type 1 neurofibromatosis. He had T4-C5 neurofibroma removed through a C3, C6 and block laminectomy. And despite the fact that the lamina were brought back in place, he unfortunately developed kyphotic deformity and, of course, cervical myelopathy, the latter being a result of the spinal cord stretching over the dorsal aspect of vertebral bodies and tensioning in the so-called bowstring effect. CT excluded a spontaneous bony union and ankylosis, which typically develops between posterior elements, particularly articular facets, while X-rays of the cervical spine during the passive extension, which I call, let's say, hinge test, showed 15 degrees reduction of kyphosis, meaning that the curve of the deformity wasn't that stiff. So now my question is, what approach would you employ to correct this deformity? Solely anterior, solely posterior, anterior posterior, or vice versa, posterior anterior, and maybe others, let's say 540 degrees, or maybe another.
Okay, so now it's open for voting. Okay.
Okay, so majority anterior posterior. Oscar, can we vote for another question, because I believe that it is connected somehow to this first one.
The other question was which levels?
Which levels would you include in fusion? Occiput to T3, C2 to C6, or let's say C7, C2 to T1 or T2.
Okay, Andrzej, people already voted, and
yes, of course,
majority of people agree with Mike Fallon lectures.
Okay, so this is anterior posterior approach, which you suggest. So let's take a look what these approaches offers to a surgeon. What are advantages of the anterior and posterior approaches? Because combined approaches are necessary when one side of the spine has ossifications, has bony union, and has ankylosis. If you need to reconstruct the spine from anteriorly and there is ankylosis posteriorly, then you need to employ combined approach and vice versa. So anterior approach offers you the direct surgical decompression, which means that you need to decompress in case you are not able to fully correct kyphosis. And remember that in kyphosis, compression is always from the front. Next, correction is gained anteriorly through a direct destruction of the anterior column with the use of cages. And its use, the use of cages is more efficient than correction gained by leverage through pedicle or lateral mass screws exerted from the posterior. And correction is also gained, sorry, I can't have advanced my slides. And correction is also gained by lengthening of the anterior column instead of shortening it through posterior approach. And then load-bearing capacity is better achieved through anterior approach, because in kyphosis, when you don't reduce kyphosis fully, then you may expect huge load bending moments which are generated, and this is anterior column which has to resist these moments rather than posterior column. So solid fusion in anterior column resists huge anterior bending moments. So anterior approach offers you powerful soft tissue release. You can release majority of discal ligamental structures, either anterior longitudinal ligaments, posterior longitudinal ligaments, annulus fibrosus, where from the posterior approach you can only release posterior ligaments and let's say capsules of facet joints. So what are advantages of the posterior approach? The first one, and the most important, is unrestricted extension of the instrumentation, either caudally or rostrally. Second is that you can perform transverse osteotomy. Transverse osteotomy, either PSO or extension osteoclasis. And another important is that when kyphosis is very severe, when a chest rests on sternum, when you have a case of chin on chest deformity, then the only approach you can employ is only posterior approach, like in case of ankylosing spondylitis patient with chin on chest deformity. So another question, I can see here that majority of you suggests fusion from C2 to C7. That's very interesting. And nobody, of course, suggests fusion from Occiput to T3. I understand this, of course, because Occiput to C3 fusion is useless in this case. It carries many risks. First is complete elimination of head motion. Second is risk of loss of forward gaze or horizontal gaze, if you want, and risk of cervical sagittal imbalance. Let's take another possibility, C2 to C6 or C2 to C7, and let's see how it looks like. This was what I did on this boy as a first stage of operation. You can see that there is nice reduction of kyphosis, and this could work. Why? Because the whole length of the curve of the deformity is included in fusion. And second, you can see that sagittal cervical balance is well maintained, is preserved, I would say. It's far less below 40 millimeters. So it stays within the normal range. So this lowers the risk of either adjacent, let's say subjacent kyphosis on an adjacent segment disease. However, However, that boy underwent the second stage of operation. I did a week later, so I did such a construct. I was afraid that when I'm not crossing the craniothoracic junction, my patient would end up with adjacent segment, subjacent segment kyphosis. So maybe C2C6 would be enough. However, I have had some cases which ended up with similar deformities, ended up with adjacent segment kyphosis. So this is the boy, and you can see that despite the nice correction of the cervical kyphosis, this is not enough. Look at his back. There is apparently hyperlordosis, which is nothing but compensation of the lack of lordosis in cervical spine, and see that forward gaze is perfectly maintained. And of course, the boys can move his head thanks to saving this craniocervical junction. Okay, and that's all what I had to present to you.
Thank you, Andre. Very nice case and very, very illustrative. It's open to discussion. Onur, please.
Andre, it's really perfect case.
I have a comment. Do you hear me?
Yes.
Yeah, I have a comment. Congratulations. This is a very nice case, but this is a Recklinghausen neurofibromatosis. And in Saint Vincent Paul, with my boss Jean Dubousset, we always recommend to do anterior and posterior fusion. Why? Because neurofibromatosis is a systemic evolution of a pathology. And this patient has kyphosis, but he has two dystrophy of the vertebral body. So you have a major risk with the future to have some kind of recurrence of deformity. And due to the growth too, there is a risk of crankshaft phenomenon. So I mean, in this case of neurofibromatosis between before maturity, we really prefer to do anterior and posterior fusion. This is Saint Vincent Paul, Jean Dubousset attitude for a long time, but it was a really nice presentation and nice correction. Congratulations, Andres.
Thank you very much. So now, after your explanations and after your comment, I can see that I did really well because as you said, and I didn't know that, neurofibromatosis requires anterior and posterior fusion, combined 360 fusion. So my satisfaction is much better now than before this meeting.
Onur, please.
Onur?
Onur?
And I would like to add only that these pictures with X-rays were done 8 years after surgery. So the guy was something like this, 18 years old that time.
Yeah, great.
Oscar?
Yes?
Andre, congratulations. It's really a good case. You have real and cervical sagittal balance. One of my questions to Daniel Ryu, a very good spine surgeon from US. I asked him, why did you, most of the cases, why do you go to T4? The reason was most of the semispinalis starting point. So his recommendation was, I go mostly to T4. Thank you.
Thank you for your comments.
Can I make a comment?
Yes, please.
Very nice case actually, and it looks like it's done very well. But there are many similar cases that may fail afterwards. Actually, and although the spine is now straight, there is no lordosis. So I would consider adding a posterior fixation in all such cases. Another thing is that if the kyphosis angle is more than 90 degrees, there are some risk like intubation difficulty, and then anterior surgery is quite difficult. So you may start with releasing anterior ligaments, go backwards, straight it, and then come forward again. There are some such cases in very angulated kyphotic cases.
I do agree with you. I showed you a case of ankylosing spondylitis patient with chin on chest deformity, where there was no possibility to approach the spine from anterior because it was completely restricted, the approach, by jaw resting on sternum, and there was no choice but to do the whole surgery from the back. So I did transverse osteotomies of C7, and then restored the reduced kyphosis. And my worry was whether to add the anterior fusion or not. I did not that because in ankylosing spondylitis, the potential for bone ingrowth and healing is really huge and immense. So that gap which I created by extension osteotomy really filled in with the bone within 4 months' time.
In the junction, cervical thoracic junction, it may be easier to make an osteotomy, but in the mid-cervical spine or C2, C3 levels, it's quite difficult.
I do agree. Of course, I do agree. But that C7 is really easier than above because you have now to deal with vertebral artery.
Right, especially.
Any other comment, Zdrubo?
Yeah. Congratulations, Andrew, for the results. I will do the same that you did. From posterior approach, I usually like to skip C7 and remove the spinous process of C7-T1 just to facilitate the closure. And I like always the idea to go to T3 and T4. I stand long into the thoracic spine. One thing that we're gonna do differently, I don't know if I need to include C2 and C3 on diffusion. I think that if you can just between C3 and C4 and try to make horizontal C3, I was not sure if I go to C2, C3. What were your feeling during the surgery?
During surgery, and before surgery, because I deliberately planned to go up to T2. Going up to T2 eliminates the C2, C3 segment from motion. So the 50% of the total head motion against the torso will be spared and will be still available for the patients. C0, C1, and C1, C2. It's almost 50% of the total head motion in flexion, extension, and especially in axial rotation.
Okay, very good. So I don't know what you're feeling. I had prepared the case. If you have more 15 minutes or if you're tired, we can finish here. It's up to you guys.
No, okay.
Sure.
Present your case, Guy.
You present your case.
Yeah.
Well, it's very, very, very quick case because we had some dilemma on this case and just would like to listen to your opinion. It's about ankylosing spondylitis fracture. It's an 82 years old male with a CABG done 10 years ago. She had a fall from his own height, a trivial injury, admitted to a local hospital with neck pain, left arm monoparesis, grade 4 on 5, a rigid neck posterior inflection. The next day was transferred to us, external immobilization with a semi-rigid collar, a posterior neck extension, very symptomatic, already progresses to a tetraparesis, grade 3 on the left side, grade 2 on the right side, sphincter incontinence, and the low hemoglobin. And this is what you have on the X-rays. You see there is something wrong here at the C2 level. Just for the young people in the audience, just some warnings. Traditional colors can cause hyperextension in the fracture site, worsening of deformity, increase the risk of spinal cord injury. So it's very important during pre-hospital or inter-hospital transfer to take care about these patients and not force them on a board. Do some gentle axial traction, not too much, with a vector of force directly anteriorly and superiorly, and also always head and upper neck and back supported by pillows or foam wedge to help to maintain a good alignment. Any residual deformity is acceptable and can be managed intraoperatively. And of course, anytime you do a tracheal intubation, do with fibrotic assistance. This is the CT scan we got back to our institution. Basically shows something here going on the C2. And typical appearance of ankylosing spondylitis patient with fracture, with kyphosis, and the MRI showing spinal cord compression, and could rule out epidural hematoma, ossified ligamentum flavum, or disc herniation for the cause of neurological deterioration. So basic fractures are important. They are related with increased mortality, up to 50% of patients. And this is due to these long lever arms. They become very rigid spine, and they are really highly susceptible to unstable fractures. And osteoporosis just add risk of fracture. So my first question to you, in this case, I cannot launch the query. Can someone launch a query for me? Maybe John, because I'm presenting. Which kind of fracture is present? Odontoid type 3 plus C71, odontoid type 2A, odontoid type 2C, odontoid type 2 plus C71.
I've launched the polling for you, Oscar.
Okay, thank you, Osam. So, okay, Osam.
Yes, okay. So
we
we
start
start
the results. So most of people think there is an odontoid type 2 plus C71, and that's exactly correct. And most of the people would go for C1, C2 posterior fixation plus C71 anterior posterior fixation, or Occiput T3. So this covers 66% of the results. Okay. Can we, okay, so yes, people are right. This is a type 2 fracture. And as you see here, there is a fracture also of intradiscal fracture of C71. And all this was neglected in the initial X-ray, and you have to pay attention to this fact. What was the rationale for surgery? C1 local instability was the cause for neuro worsening, had to be tackled without any need for decompression. And we know that sometimes bone work in these patients cause a massive bleeding. And this would allow immediate mobilization of the patient for rehabilitation, although we know the complications of surgery, 40% infection, 50% loosening. We choose not to address the kyphotic deformity because it was an elderly patient, because of the neurological condition. And we had information that in pre-op there was no breathing or eating difficulties from this kyphosis. we decide to go to C0 and do a posterior fixation instead of odontoid screw in C1, C2 because of the age, because of the poor bone quality, the severe CT kyphosis, increased SVA and T1 tilt, and no intent to perform osteotomy. And we want to solve the problem or stabilize the patient on a single positioning and approach. This aligned intradiscal C7 T1 fracture, it's a good indication for posterior fixation, and you should go, you should have fixation points at least 2 above and below the fracture. And whenever this occurs in middle cervical fracture, you should extend beyond to the thoracic spine. This is what we did, intraoperative reduction and then monitoring, and we did a C0 T3 posterior fixation. And this is the result. Our aim was just to stabilize and not to correct the deformity. And no post-op external immobilization, no surgical complications. Patient had a pneumonia that was treated successfully, was discharged to rehabilitation with a slightly neurological improvement. And we learned that the patient died 3 months later from respiratory complication. And these patients, really older patients, have a high rate of mortality. So the take-home message is long lever arms cranially and caudally of the fracture interfere with bone healing, and high rates of union will result if sufficient stability is not provided. So I believe surgical stabilization is recommended for most of these patients, and that's a trend that we are seeing in Sweden. And one of our friends from the CSRS published very nice work on that, and 70% of patients are now being operated. And long stabilization is effective method of regaining stability without the need for additional external immobilization after surgery with a relatively low complication rate. We know we have wound infections, we have pulmonary infections. This can add to the mortality. However, surgery has a positive effect. The role of anterior approach is very limited. They are reserved for long anterior column gaps, kyphotic deformity, if there is a fracture at the level of the vertebral body, or if you have a reducible anterior fragment that rarely occur in these hyperextension fractures. It increases morbidity, time, and comorbidities in these patients with cardiopulmonary problems. And as we said before, in highly kyphotic patients, the anterior access is anatomically impossible. So stability improves with increasing the length of the construct. Long constructs are the primary choice with multiple points to avoid longer lever arms and because of osteoporosis. And we thought about this question of skipping some screws long construct. This is something that we do or in scoliosis surgery. Apparently there is no reduction on the construct stability and reduces the stress of the instrumentation on the cranial end, can reduce the costs and the screw malpositioning issues. That's something we can discuss. So thank you, and I would like you to follow up and stay tuned with our annual meeting that will take place sometime next year, probably in June in Paris, and Philippe Bancel is the chairman. Thank you.
Thank you.
Thank you.
Thank you, Oscar.
Great.
Okay, so any comments?
Oscar, can I just comment? Do you think, yes, do you think it was necessary to go to the occiput? I mean, you fixed C1 lateral mass. Do you think it was necessary to fix to the occiput? The second question would be, do you think you needed to fix from the whole long or just maybe 2 constructs, C1, C2, and maybe C60T2 for the C71 fracture?
I mean, assuming that this patient would recover nicely from his neurological condition, I think if you leave a gap in between instrumentation, you risk a fracture over there on the next fall or next minor accident. So I think it's advised to do a long construct. And as Mehmet showed before, I think these patients with AS, you need most of the time to go to the occiput. There is always some degree of instability.
Thank you very much. Excellent presentation.
Just a comment, Oscar, excellent presentation and excellent case in this huge challenge. I'd like to only tell that in cases of fractures, especially fractures dislocations in ankylosing spondylitis patients, I take this opportunity and correct the kyphotic alignment of the spine just at the level of fracture. So you can fix the spine in a position as you like, because it's already fractured here, and natural post-traumatic osteotomy is already done. So
no, yeah, Andre, I agree with you. I mean, this was our main question, but this was an old patient with a bad.
No, I'm not talking about your patient. I'm talking, of course, you did this very well. I'm talking about other patients, younger patients who have.
Yeah, you have younger patient, better neurology. I think it's a good option to do C7 or whatever T1 osteotomy and just correct.
No, I'm not talking about osteotomy. I'm talking about that if the patient has already fracture at the level of C-spine, so you can align the spine during fixation at any angle you want, because it's osteotomy is, let's say, traumatic osteotomy is already done.
Right.
But this particular case, there was no osteotomy, there was no fracture in the posterior elements, it was just a crack at the front. So actually to mobilize it and correct through it needed...
No, I'm not talking about this case. I'm talking about other cases. This case I would do as well, the same way as Oscar did, if I managed, of course.
Yeah, Andre is right. Yeah, sometimes it's so mobile that if there is previously a lack of gaze, yeah, you can mobilize the fracture and just open anteriorly and use the mobility of the fracture just to reduce the kyphosis. I agree with you. Yeah, sometimes that happens and it's very easy. Hop, you take the head and you're opening the anterior column and you close the posterior column. Just do the mobility of the fracture and you can do everything. I mean, you correct the deformity plus you stabilize the fractures. This is a good, this is a good, very good idea.
That's what I mean, exactly, but didn't manage to express.
Great.
Andres Cambalia is with us. He's a member of the CSRS board. Andres, you want to make a comment?
Oh, thank you. Thank you so much. It is an excellent meeting, an excellent discussion. And this last case presented is quite interesting. I have some doubts about, because it's an ankylosing spondylitis, and for this, really the best is to fix all the spine, all the cervical spine, with or without occipital, no? But I think that you have resolved the case in an excellent manner. Also remember that there's quite morbidity with all these patients, and finally, 3 months later, no, he had complications in respiratory. But
thank you.
Very well resolved.
Well, thank you, Andreas, for being here.
Oh yes, of course.
Onur, you have always different thoughts out of the box. What's your comment?
Oscar.
Yes, Onur.
Thank you so much. Such a beautiful meeting. It's really fantastic. The presentations were very well. The talkers, all the comments were fine. Thank you so much.
Okay. So Mike, thank you for Mike, Jyoti, Mehmet, everybody, Osam, Andre. I don't see you a long time, Andre.
So did I.
I think you keep a good taste with shirts, as in Glasgow, back in Glasgow. The guy had also the most wonderful shirts.
So you also keep the good shape. Still young man.
Zubal, was great to have you here. You did a really nice piece of research just for this webinar, and I have to thank you about that. So this was really a wonderful meeting. This is the kind of discussion we want to have, and I will invite you all to come to Paris.
Thank you.
Philippe may want to say some words, but this is the kind of spirit we have in our meetings in Paris next year and in the previous meetings. And I'll invite you all to come to Paris. Philippe, do you want to say some words?
Yeah, first of all, I would like to say to you guys, Oscar, you've done a really big job. And I would like to say hello to all my friends like you, Osuna and Honor, and every of you guys. And I really want you to come. You have been really great. You're arguing. And in Paris, the atmosphere very nice. So, you know, you can talk to us, you can just, you know, as Ono said and done, you know, you can really argue us, and it can be a very big feeling and big atmosphere in May in Paris. So guys, join us and keep going like that, and stay healthy, guys, too.
Okay. So thank you, everybody. It was a real pleasure to have you on board, and thank you for your contribution. Thank you. Thank you so much.
Thank you, Oscar. Thank you, everyone.
Bye-bye. Bye-bye.
You guys.